Hi everyone, my name is Devin and I'm one of the senior trainers of MRAP this year. And I just wanted to make an updated ED COUP video for you all, considering the fact that we've made a couple changes to the study since our last video was posted. The main one being that we're no longer enrolling our chronic pain cohort, which was, of course, a really big part of our screening process. So the study is actually quite a bit simpler to screen for now. So yeah, I just wanted to do a bit of a refresher on some of the background information of the study, as well as walking through the screening process for you again. And if you still have any questions left over at the end, please feel free to reach out to the senior trainer email or the head trainer email. So to start off, ED COUP stands for ED complex opioid using patients. Our two main investigators here are Dr. Stephen Henry, which is our principal investigator, and Dr. Amy Moulin. The study started January 18th of 2022, and the completion date is still to be determined. So to start off, I just wanted to talk a bit about some background information of opioid use disorder, or I'll refer to it as OUD. It's also known as opioid addiction and dependence. And before I talk about it, I just want to quickly stress person-centered language. You might have heard about it in your new RA class, but essentially this just allows us to affirm agency and humanity. It's something that we really try to emphasize in MRAP, especially when we're talking about patients in the emergency department. So if you ever come across an OUD patient, for example, just make sure to refer to them, for example, as like a person with a substance use disorder rather than an addict. It's just a way that we can make that environment a bit more warm and friendly and understanding. So to get into OUD, it's essentially just a physical or psychological reliance on opioids. And as you may know, opioids are substances that are found in certain prescription pain medications, as well as street drugs like heroin. And the issue with these drugs is that they can become less effective over time because prolonged use essentially results in greater quantities being required to feel any difference in pain relief. A lot of people turn to opioids for pain relief. Um, and so, because of this dependence, patients who stop using opioids experience severe withdrawal symptoms that can be incredibly uncomfortable. A lot of the time, opioids are actually prescribed in a clinical setting for pain management. This can be after any sort of like big procedure, like surgeries. And the four primary opioids that we'll be seeing in the ED are used for acute pain treatment, and they are morphine, meperidine, fentanyl, and hydromorphone. There are also some trade names which are on the screening document that's on campus. So next, I want to talk about actually another opioid. It's called buprenorphine, and this is actually an opioid that's used to treat OUD through a medication-assisted treatment plan. So once the body has formed a dependence on opioids after a period of sustained use or misuse, taking the opioids away cold turkey can result in really unpleasant withdrawal symptoms throughout the body. So this can be anxiety, agitation, muscle aches and cramping, insomnia, yawning, sweating, etc., which of course is really challenging for anyone who's trying to quit. So essentially, buprenorphine can be prescribed by a physician, and it prevents participants from experiencing these withdrawal symptoms or cravings, which can allow them to focus on their recovery. And this will prevent them from turning to other more dangerous alternatives like heroin and other street drugs. So a bit of background information about why we have this study in the first place. A lot of times when patients come into the emergency room, they might be coming in for one main issue that they're having at the time, but they often have many medical and behavioral comorbidities. But lots of studies that you'll see will tend to focus on just one condition at a time. So treatment for these very complex patients is frequently siloed, especially for patients who have any sort of substance use disorder or mental health problems, as well as chronic pain. And so this can lead to much less of an effective treatment than a coordinated care approach. So UC Davis Medical Center is a leader in this national movement to identify and offer treatment to these complex patients with any problem that involves opioids. So this could be either people who are using prescription pain medications for chronic pain, for example, or turning to street drugs like heroin, and help connect them to an outpatient treatment. So this is essentially what the California Bridge program is and stands for. And they're disrupting the addiction treatment landscape by championing the idea that substance use disorder is a condition that should be treated by medical professionals like any other life-threatening condition. So the issue is that most medical providers don't view addiction treatment as part of their job. So people who use these drugs are often highly stigmatized, They'll be treated for their other conditions and then just sent on their way with a list of often very inaccessible specialty addiction clinics. So they're not able to get the help that they really need. So the goal of the California Bridge program is to transform addiction treatment by ensuring that every single hospital in California is able to provide 24/7 access to evidence-based care, which is really, really interesting. I highly recommend looking more into it if that is something that interests you. I've included a link at the end of this presentation if you're interested in learning more. So on to the purpose of ED-COUP. So it's, like I mentioned, a bit less complex now that we're no longer enrolling a chronic pain cohort. So essentially our goal with this is just to recruit a group of English or Spanish speaking participants from the emergency department who have opioid use disorder and are started on buprenorphine by their physician. And we want to follow these patients for several months to collect better data about their treatment needs. And these results will be used to improve patient treatment and also to design larger studies to see how we can help the care of these patients with opioid-related problems. So now I just want to get a bit into our inclusion and exclusion criteria. This is what we're looking for when we're screening. As you may know, our responsibilities as RAs for the study are simply to screen for any potential eligible patients and let the RC and JS know if we found any and assist them with anything they might need. So I'm just going to walk through how we might typically start screening. So the first thing we're going to do is just rule out some basic information. So we're not going to be enrolling minors in this study. If you see anyone who's under the age of 18, you're going to immediately exclude them, as well as if they're in a vulnerable population, so like a prisoner, we're going to exclude those patients. And then if they speak a language other than what we're able to enroll them in, so that would just be English or Spanish, we're also going to exclude those patients. And if they don't meet any of those exclusion criteria, we're just going to continue on to the next section. And the questions we were going to be asking in this section are if they have any mention of withdrawal on their chart or any heroin use, fentanyl use, or explicitly OUD is mentioned in their chart. This is all going to be regardless of what chief complaint they come in with. So you can screen anyone for this study really, as long as they don't meet the exclusion criteria. If they have any mention of drug overdose, or if there's any mention of buprenorphine on their chart or medication list. So if the answer is yes to any of these questions, you're going to ask you're going to let the RC or JS know, and they might ask the treating provider or substance use navigator if they're considering prescribing buprenorphine for the patient. And if the answer is yes, the patient is going to be eligible. And if the answer is no to all of the above, we're just going to exclude them. Another helpful thing to look for, which I'll touch on the next slide, is if they've been referred to a substance use navigator. That can be a really good indication that we're dealing with an OUD patient. So yeah, that's about it for inclusion exclusion criteria. As for our responsibilities, like I mentioned, we're really just kind of helping with the screening process and letting the RC or JS know of any potential patients. And now that we are no longer enrolling the chronic pain cohort, there's actually a lot less chief complaints that we could look for that could indicate potential patients. Now we're kind of just looking for patients regardless of what their CC is, but it does help if you see any like indication of withdrawal in their chief complaint section. I've actually explicitly seen the word withdrawal once before. That obviously can be a great indication that you're on the right track. But then other things we can look for is in the doc plan tab, there could be a SUN referral. There could also be a prescribed buprenorphine note, but this is going to be more likely in MAR. So once we go into this patient's chart, if you want to check the home medications list, this could also potentially have a buprenorphine indication on there. And the important thing to note is that if you are looking at the home medication list, you're going to want to refer to the opioid list on the screening sheet that's provided on Canvas, because buprenorphine actually has 4 different trade names as well. I think you most likely would see it written as buprenorphine, but it's always something to keep in mind that there are trade names for a lot of these opioids. And then, of course, the medical administration record, that's going to be where we'll often find a buprenorphine prescription. And then it's also really good to check the demographics section to confirm what language the patient speaks, because again, we're only enrolling English or Spanish speaking patients. So that about sums it up for our responsibilities, as well as the entire presentation. It is quite a bit of a shorter video than the older one, just because that chronic pain cohort really was most of what we were screening for. It was most of the screening process. It was very involved. So hopefully that makes sense to you guys. If you have any additional questions, please feel free to reach out. I have all the links to all of the sources that I used, as well as the California Bridge program if you're at all interested in learning more about that. And thank you so much for everything you do. Don't hesitate to reach out with any questions. And I hope you guys all take care and stay safe.